Going live in now. Hello, everybody. Back to session one. We're officially starting the COVID-19 Digital Orthopedic Response. And our first guest, our honored guest, is Professor Dr. Wang from the Chinese surgeon. He's the chief surgeon of the Chinese PLA General Hospital in Beijing. We could not think of a better person to introduce us to what has been happening in China. Welcome, Dr. Wang.
Hi, thank you. Yeah, Dr. Benny.
We're extremely excited for you to be here, and your experience, plus as a leader in China, you've been president of the member of the Hip Society, you're chairman of the Orthopaedic Society in Asia, you're associated with JOA. There just could not be a better person to bring us up to date with what has been happening.
Thank you.
I'm going to turn the podium over to you. I'm going to let everybody have a look at the beginning of slide deck, and we'll get going.
Okay, thank you. I'm Dr. Wang from Peking, China. Thanks for Dr. Benny, who invited me to share experience with all of your participants. Thank you. So, first, like to we're talking about the first retrospective epidemic, the trend in China. The first. The COVID-19 initial outbreak in Wuhan, China, and spread rapidly. At the beginning, we can only see upward trajectory, the peak. We now see the epicenter, whatever, in the Spain and the Italy and the New York City. There's always sees upward trajectory, yes, peak, and which is similar with most of the center of the world. In order to curb the spread of the infection, the Wuhan make lockdown sacrifice with tough measures I will talking about later. It takes us 3 months to flatten the curves, and China was now effectively control the epidemic. And so we're talking about dilemma. Sorry. Dilemma. So we meet the dilemma, the same situation with you guys meet the beginning. We are shortening of the medical resource in the PPE, personal protective equipment, and we are also lacking of the test kits, ventilators, the medical staffs, and other critical items. So also we need government to ramp up the testing availability. Yes, you can't test the people. You can't isolate the right people. So our hospital surgeons, even our works, we're talking about the hospital surgeons, and our ORs phase to be deployed to help tackle the surge of the virus. So I was talking about and present measures were taken in China. The first is Wuhan in locking down, and the other city is an tight restriction. So also for APP, we're available for tracking civilians of the confirmed case and the close contacts, and expanding test capacity. And also the army sent the 4,000 military medical staffs and medical resource, and followed by 42,600 medical staff and 46 teams from 31 provinces nationwide, and with 19,000 ICU professionals and 67 unit coma. And also, except for that measures, also we quickly for 14 makeshift hospital, as now you see, almost the same. And 13,000 available beds for mild case. And 2 new hospitals were completed in 10 days for severe and critical cases. So we're talking about orthopedics protocol in epicenter. And all elective surgery were suspended. And the emergency surgery in designated hospital and confirmed case were performed in the negative pressure or OR. And some of, I'm talking about orthopedic surgeon ward and OR were recruited to anti-epidemic. For our emergency, so we're talking about, first we're talking about epicenter in Wuhan. We benefit from the strict lockdown of Wuhan. The other part, the condition in our part of China is not severe. For example, my hospital, I institute in Beijing, is with more than 20 million population, but only have the less than the 600 confirmed cases. So our experience for our emergency protocols, for example, is we set up a special fever clinic for initial pre-screening and COVID-19 test, for all the patients who admitted to the hospital. And because delay something for test case, we have the long CT scanning that's very sensitive. It's another alternatives, very sensitive to you can see the pictures. And the emergency, the surgery indicated include trauma, the acute PGI, the fracture and the dislocation, and some other neurological deficit. And other surgery should be postponed. For the outpatient, for our outpatient protocol during the height of the pandemic, and online outpatient is a priority. Our institute has established a 5G remote consultation platform which can conduct immersive video and allow for instant virtual communications, which helps patients to access to medical treatment, avoid risk of the epidemic spread. Additionally, some online outpatient clinical APP, for example, WeChat in mobile phone, also provided the consultant, the pre-screening and the chat as service. For inpatient protocol, for how to make the team management, we have 3 teams rotated, including residents, the fellows, and attending doctors. Instead of the daily morning conference, my team set up online conference via WeChat apps, discuss the case and determine surgical plans. Also, in that time, in the spare time, also online education is available, for the regular online for team members and other colleagues. And in worse, the patient are isolated room and required to wear the mask throughout all the process, from the beginning to the emergency to the hospital. Here I emphasize the regular the people to wear the mask, because recently the WHO have to confirm that the virus is airborne. they could suspend it in the air for hours. And also for the patients, the cough, the droplet, the coughing, they can go 6 meters even. So for even for not only for the patient to the hospital, but you can see in Korea, the South Korea, China, Japan, in the Far East Asia, the people, regular people, is take the regular wear the masks to protect themselves. That's a differential was the guideline from the states. Yeah. So the masks are required not only for medical staff but also for patient that addressing the measures conduct to prevent the spread the coronavirus in some extent. So I'm talking about the in the elective surgery, the protocol is the most elective surgery are postponed, and the relatively urgent surgery with full PPE. Take the test case for all the patient for operation. A long CT is also available. And for elective surgery in our center is for acute PGR in a progressive neurological progressions. So for summary, for epicenter, for example, in the Wuhan in China, in the New York City, for example, in the United States, all the elective surgery should be suspended. For now, epicenter, the surgery should be performed with strict pre-screening. Facing the aftermath of the COVID-19, we need to be vigilant to imported and asymptomatic case to avoid secondary circles of virus until the vaccine or drug are developed. We really need to be prepared for another circles. Never before, the research says have so many experts in so many countries like here now, the focus simultaneously on a single topic. We are all in this together. Globally, solidarity, collaboration, and urgent action are leading us to defeat the COVID-19. We can win the battle against COVID-19 together. Thank you.
Dr. Wang, that was outstanding. I learned a ton. I was really excited to see some of the pictures of the hospitals you had built. There's been so much going on and so many questions asked about that. It was very impressive how China responded and how your team specifically responded. So now we have a few minutes to get into some questions. I will look forward to the audience asking as many as they'd like. Just go to the Ask a Question button at the bottom of the screen, and we'll get started with the one that has received the most votes, which is at what point in the curve is it appropriate to return to elective orthopedic procedures?
We differential. For example, in China, for epicenter of the epidemic, for example, in Wuhan, all the elective surgery or cancer is suspended. But in our part, it's something like the Beijing and other cities, we are according to the priority, except for the emergency operation, but some elective surgery even for the PGI and fractures and even the joint replacement for the femoral and the neurological deficit progress of the neurodevelopment is But the protocol is all the operated patients must be mandatory for testing for regularly. Because actually we have no experience in my institute for the confirmed case of the virus, but my colleagues in Wuhan, they have the positive virus case for an emergency case. But in that part, all the patients sent to the designated hospital.
So the people who are positive are treated, but they go to a designated hospital.
Yes.
And in Wuhan, have they started operating normally again, or are they still holding back on the surgery?
Not
still
yet.
Holding back.
Yeah, not yet.
So when do you think will it be appropriate for them to start operating again in Wuhan?
But now, for example, in Beijing, in our hospital and other the key world hospital, they begin to open the outpatient clinics and some the elective surgeries. But now Wuhan, maybe I think they will gradually begin. Yeah, maybe after 2 weeks. Yeah, because the incubation for all the infection of patients, so they will begin. Our heard, to begin to open the outpatient clinics.
Excellent. Let me ask you another question that it's on everybody's mind, of course, and during the course of the conference, we'll be addressing this several times. The question of the risk of transmission to the care team, whether it's the surgeon, the anesthesiologist, the nurse caring for a sick patient. What did you hear from Wuhan about the risk of transmission as we're caring for these patients?
Yeah, that's a good question. I heard of the situation in Wuhan, in the epicenter, in the outbreak. In that time, only local the medical workers in the front line. Then they were talking lack of the medical resource, especially the PPE, even the mask. Even you can see the picture. They made himself for the gauze protection for himself. So they have some the high infections rates. But after we're talking about the military medical workers and the nationwide the medical works to join the fight in Wuhan. They have very because they come from nationwide, that enough the full of the medical resource, even the protective equipment or whatever, the ventilator, all the kind of, but very low infection rate for after that.
So once you've applied the PPE, the infection rate was very low. Yeah, I've seen that from a number of studies as well, but everybody's quite concerned about it. It seems like with the high aerosolized procedures like tracheostomies, bronchoscopies, those are higher risk. But if there isn't a lot of that happening, usually with the PPE, it looks like the infection risk is low. Excellent. The next question that comes up is, in the outpatient clinic, when you're seeing patients as you're opening up the clinics again, are you asking your staff to wear PPE? And how much? Is it just the mask or the full cover in the clinic?
Thank you. It's not that like the epicenter. It's just the mask. Yeah,
just the mask.
Yeah.
The next question has to do with testing. And there is a high false negative test. In the United States, they're reporting between 25 and 30% false negative tests. So that means that even if you test somebody, they may still be positive or at the beginning of their treatment. So does that change how you treat a patient with respect to especially trauma patients? if they test negative, do you still treat them in a negative hospital, or do you, if they're at high risk of had high contacts, do you just say you're assumed positive, you have some symptoms, we treat you in the COVID-19 specialty hospital? You know what I'm saying? That patient in the middle, they're symptomatic, but they're negative.
Yeah, a good question. I mentioned about our protocol for whatever, for in an outbreak, for emergency patient, for the open fracture, open soft tissue injury, for that kind of patient, all patients with mandatory for the test kit, but always the beginning, they have some delay. So for that of the suspected patient, we are plus of the routinely use CT scan for lungs, because that's this option, for enhance the screen.
So CT scan.
CT scan.
Well, let's talk a little bit about that, because you mentioned in your presentation that lung CTs were being done for all patients. I understand some people have written that the lung CT is even more diagnostic than the blood tests, or the CRP test. So tell me about that. Is everybody who is admitted to the hospital screened with a CT scan as well, or is that only the pulmonary issues? How often do you get a CT scan?
Actually, in the beginning, we are both for all the admitted, the operation patient, test kit and the CT scan of the lung together to for all the patients, because it's high infectious, for you're talking about, especially for our frontline medical staff is anesthesists. They are So we're we in our institute, we have the two negative pressure operating room, but never used, because we have not such the positive.
The testing question keeps coming up in different ways, so let me ask another way. Dr. Macheras asks, are we justified to ask for testing all emergency surgeries before surgery? Should you be testing everyone who comes in with a hip fracture, for example?
Yes. Our protocol, testing all the admitted patients for operation.
And right now, the testing time in your hospital is, how long does it take to get a result?
That's a problem. At the beginning, at least for 1 day, delays. So for that situation, we combine with long CT scanning.
Right, that was a question that's come up, but Dr. Indeli at Stanford also asked whether they should perform a lung CT on all trauma patients. So we just answered the question about a viral screen, but do you also get a CT scan on all trauma patients?
Yes.
Thank you. In terms of masks, are you okay with a surgical mask, or do you need an N95 mask?
Actually, we surgical mask for all our staff. Only for the anesthesists, they use N95, the masks.
Great.
And also not only, but I'm talking about for all the patients from the beginning that come to the hospital, emergency, all the process must wear the mask.
Are you starting to get a sense? There's a question from Dr. Barber in New York. What is your experience testing asymptomatic patients? I think he's wondering what percentage of the population that is asymptomatic are you starting to think is actually a carrier? He's quoting in New York, they're thinking around 6%. I've seen data from CDC as high as 20%. What percentage of COVID positive patients are you thinking now with some experience are actually asymptomatic, feeling fine?
Yes, a good question. Yeah. And why the rapid spread of the infection? The one is, that's the one that the person have the asymptomatic, the patient, confirmed patient. And also I report some patients before the sick, they also can have spread, the infections. So that's why for all the patients, whatever in our clinical, for emergency or elective surgery, all the patients test case. Now, even not only once, maybe twice, because they have some percentage of the negative.
This is an interesting question as well from Henaro. Is it used to save helmets? I'm not sure, the helmets that we use in arthroplasty with the air recirculation devices, those actually can work two ways because they don't have HEPA filtration in them. Do you think those are safe to use?
Yes. So even, for example, that's you regularly used by arthroplasty, recon surgery. But now it's routine. Now, even for spine, for neurological, they with the air burst for GAUS for get more.
So everybody's using the helmets. Not just the surgical mask, but the helmet, no matter what surgery.
It's during the surgery, I mean.
Interesting question about the surgical technique. Is there any way differently for gowning? I can't imagine that would change much, but for the nurse and the doctor putting on gowns, that nothing changed there. Is that correct?
Yeah, it's no big difference, but after, because not so much operation, so the one patient isolated 1 hours, not follow the second operation, but they go to different isolated OR room. So we just restrict that.
I don't know if you have many ambulatory centers in China. In the United States, we have a large, I don't know how many, but there's a significant percentage of our hospitals are outpatient ambulatory surgery centers that don't have any inpatient units. They don't have any people go home. Do you have much experience with those? And if so, do you think they should be considered differently from inpatient hospitals? In other words, could we be using those outpatient centers for limited procedures, given that there isn't that large concentration of COVID positive patients in there?
So actually in the big city in China, in Shanghai, Beijing center, they have the lots the keynote, the big hospitals. It's enough the inpatient wards. Not like even Wuhan is not like the Beijing and Shanghai. So actually in the beginning in Wuhan, the epicenter, the outbreak, the lack of we're talking about the hospital wards and all the medical resource, and it's different. So after the nationwide support, medical workers, the medical resource support the Wuhan is much better, getting better. But in Beijing, Shanghai, we have not so much lack of the medical resource.
Question from Kevin in New York City. He wants to know whether all your trauma patients, the non-elective surgery that is being done, if all those patients are getting chloroquine.
Chloroquine. So what was it?
The anti-malarial drug that chloroquine, hydrochloroquine. Are all the patients getting that who are having trauma patients?
No. So actually, in not popular use in China, because even to the recently the chief the chief officer, leading expert infectious disease, Dr. Sachi, has mentioned about by now it's no efficient drugs for COVID-19 virus. So in actually 80, even more than 80% of the mild patient can cure by himself. Yeah. Only some severe patient. I don't think that's kind of the drugs play a key.
So no, we don't. We're not giving chloroquine to everybody, just the very sick. Yeah. Okay. Is using positive pressure ventilation is used in a lot of operating rooms. Could that be a problem in the context of COVID-19? Is it in this positive? You know how some operating rooms have positive pressure ventilation to prevent airflow. Have you turned those off or on in your operating rooms, or you just you don't think it matters?
No. Yeah, we only have 2 negative pressure. All other OR is the positive pressures. It's no restricted.
Okay. There's been some people saying that you have to be careful with surgery not to use reamers or brooches or limit the amount of reaming to avoid aerosolization. Have you found that to be an important aspect of how you change your protocols as a result of the epidemic or the virus?
That's zero, because we have the very strict protection. The PPE with the space gauge, so that's don't
So you feel like you're covered enough. It's okay.
Yeah.
There is a question about how often you're testing, if at all, surgeons for screening. Do you test surgeons for screening?
Yes, we are regular. Yeah, we test our surgeons who have close contact, for some emergency and in a regular team in a duty in the inpatient ward, and anesthesists, of course.
Okay. So there's a lot of questions about how complete PPE has to be. And what I'm hearing you say is if you're in a high risk environment, it's important to wear the whole gown and coverage. But if it's low risk, not much aerosol, a mask is sufficient?
Yeah, I understand. So I'm talking about, yes. Because that's the crucial for protect our frontline, the medical workers. So I'm talking about in the beginning, the outbreak in Wuhan, a lot of surgeons, doctors get infections. But with national support, not only the medical works, but also the PPE enough that's crucial for protect our medical frontline, the medical workers.
And there's a question here from Chris Brigham, and it's about the clinic. And it's a topic we'll be discussing quite a bit over the next 2 days, is how to perform the physical examination virtually using the technology you showed us. And what did you learn about how to do that effectively?
Actually, for emergency room, it's not virtual, it's a close contact. Yeah, it's of course. But for the outpatient, I'm talking about the online outpatient is the priority. Yeah, but only we at least avoid to close contact for this kind of the patient. Also, we can see our platform. Even we could not in person to how can I examine the patient, but the instant, the virtual, yeah, it gives some help.
There are quite a few people who have asked questions, which I think were answered already. So I'm just going to quickly go through them. The the helmets are actually used and actually encouraged to be used for all surgery. Dr. Wang told us, so it's a good way to increase protection. And it seems like the air recirculation is not a problem. It is recommended to test all patients with fragility fractures. Basically, anybody coming into the hospital and being treated is being tested. Maybe we can talk about this a little bit, and probably the last question. What criteria have you employed to prioritize trauma surgery, and actually even prioritize any surgery? Do you have strict criteria in place?
Of course, it's open, yeah. Injury, yeah, it's a priority for trauma guys, of course, yeah. So
trauma, open fractures, hip fractures probably get prioritized?
Yeah, open, soft, it's open injuries, yeah, such a more, it's a priorities.
If you have a fracture of the forearm that could be treated either with a plate or a cast, do you avoid the surgery and try to treat conservatively?
Yeah, of course, conservatively, yeah. Because even, we have the test that, you have some negative, some, currency.
Well, I just want to take a moment to thank not only the audience for their excellent questions, but Dr. Wang, it's been an absolute pleasure to have you on the broadcast and joining us and giving us your insight and your experience. It's been very impressive what you and your colleagues have been able to achieve to stem what looked like a out of control epidemic, and you guys did what had to be done. The construction of the hospitals and also the sharing of the information so the rest of us could learn from you has been wonderful. And as you pointed out at the beginning, the collaboration across country lines has been appreciated and something we hope we continue. With that, I'd like to, again, thank you very much for your participation. Close this session. Is there any last thoughts you'd like to share with us?
Thank you. Thank you. Thank you. Everybody, thank you.
Outstanding. And thank you also for your team over there. With that, ladies and gentlemen, I'm going to turn the podium over to my colleague, Shauna Butler, who in the next session is going to be interviewing Dr. Luigi Zagra, who is in the epicenter in Italy, in Milan, and will be sharing with us their experience. So with that, I will see you on the next session after that. Thank you very much.
Thank you, Vinny.